To our ID series. A few announcements before we get started. Welcome to the Innovative Discovery Series. Instructions to obtain CME credit are on the screen currently. We can also email instructions if you provide your address on the sign-in sheet. A couple upcoming announcements. Next Thursday, our Tech Talk will be Dr. Mina Astavari, who is going to be talking to us about network analysis, a methodological approach for studying collaborations in healthcare systems. Hope to see you all there next Thursday. And then a week after that, ID Series returns to our regularly Friday schedule on February 14th. Valentine's Day. We will be hearing from Dr. Jennifer Taylor from Drexel University, who will be talking about organizational culture and safety and firefighter injury research. So please register through the ChristianaCare portal. The full ID series schedule is posted on ACCEL, DE-CTR.org. This afternoon, it is my pleasure to introduce Dr. Russ Kirby, who is the Distinguished Professor and Marrell Endowed Chair at the University of South Florida. I printed out Dr. Kirby's CV to prepare for my introduction, and then 2 hours later, it came out of the printer, so I will try to make this short. I think it's just under 100 pages, so he has had an amazing career, and we're very happy to have him with us. Of some of his noted highlights is that he has authored more than 300 peer-reviewed articles and actually has connected with over 700 different co-authors. He actively participates in the editorial process, is a peer reviewer and editorial board member on numerous journals. He's been a perinatal and pediatric epidemiologist since 1981, so for the past few decades. Has been working in this field. He's worked at state health agencies in Wisconsin and Arkansas, and has been on the faculty of the Department of Pediatrics at the University of Arkansas for Medical Sciences and the Department of Obstetrics and Gynecology at the Milwaukee Clinical Campus at the University of Wisconsin Medical School. He also served on faculty at the School of Public Health at the University of Alabama, Birmingham, prior to joining faculty where he currently is at the University of South Florida. We're really looking forward to Dr. Kirby's talk this afternoon. On a final note, as you may have noticed, we changed our Innovative Discovery Series to Thursday this week because I believe tomorrow Dr. Kirby flies back to Florida for a harmonica performance, and which is very fitting because as those of us who have worked in understanding the effects of place on health, which we'll hear a little bit about this afternoon, you know that making maps is like playing the harmonica. It looks easy until you try it. So please join me this afternoon in welcoming Dr. Kirby to ChristianaCare.
Well, actually, the thing about the harmonica is to keep working at it. And I actually started playing the harmonica when I was 14, so I've been playing for 50 years. And I think maybe I have learned something about it over time. It's not like riding a bicycle, you never forget how to ride a bicycle. But, Okay, so objective in terms of this, is really to, give a call out for incorporating the spatial perspective into research. And my examples are going to be in maternal and child health, but it really needs to be part of research across the whole spectrum of the age continuum as well. So we'll look at some analytical methods, give you some examples, give you opportunities to think about how some of these methods can be applied, and I'll throw in a few other things, and I've always had my sense of humor as well. So my disclosure slide, the most important thing on here is that I harm no laboratory animals, family pets, or wildlife. And I do want to point out that a lot of the things I'm going to present are based on some collaborations that we've been doing in Florida and elsewhere. And then conflicts of interest, everybody, one has to disclose these kinds of things as well. I do have funding from CDC, from the Florida Department of Health. Don't currently have funding from the March of Dimes, but did recently. I also am on a scientific advisory committee for a pregnancy registry for Jazz Pharmaceuticals and have done that work for other companies as well. Actually, that's not the best way to get peer-reviewed papers, but actually I did get one from each of those previous ones, one on Botox and one on end plate. So there is some opportunity there. And I'm also a great believer in being involved professionally in organizations that support our work. I've been actually president of 4 national organizations over the years, and you learn so much more about what our field is all about by getting involved in those kind of things. I would definitely encourage all of you to think about getting involved at least at committee level in at least one professional organization, because it's very rewarding. And Dr. Pappas and I are, we actually formally met at ACE last fall and had the opportunity to work together during the awards ceremony for ACE. Okay, and I do love music and so on, but I thought since it's lunchtime, I would start out with something that's maybe a little bit humorous. And so I put together a few years ago a top 10 list of how to do health services research badly. And I guarantee you, if you do some of the things on this list, many of which some of us have probably done, we'll end up doing things badly. So first of all, when you're doing economic analysis, it's fine to use the terms cost and charges interchangeably, because after all, they are the same thing. When somebody gets their bill for services and it's $38,000, and then the insurance company gets to write off $29,000 and pays almost all the rest, right? Well, there's no difference really between what they charge and what the cost is. Okay, now it's very important to know that the only people who can do health services research are people who are formally trained in health services research. And given that that's true, you don't really need a multidisciplinary team to do health services research. And you won't really gain anything much by having a geographer or a sociologist or a data scientist or whatever. In fact, all they do is make it harder to design and conduct the study. So why bother with a multidisciplinary team? Okay, again, to do it badly. Then we have the issue around when we do our analyses, definitely we should only focus on different aspects at the individual level and forget about the fact that differences of patients, providers, hospital, community are actually at different levels of aggregation that needs to be controlled in your analysis. And if you forget about that, you're probably going to do research badly. And if you don't believe me, just look in the literature and you can find lots of examples where people do it badly. Number 7, there's no need to risk adjust. So you just tell people that, the reason why our outcomes are worse is because our patients are sicker. That's why our outcomes are bad. And of course, the way to improve is to attract healthier patients to your facility, and then your outcomes will be better. Okay, number 6, using a pre-post design to study changes in outcome, but don't have a comparison group. And then, of course, don't worry about regression to the mean, because after all, that's not a real thing, okay? And of course, if you want to have the best possible results, you want to have the sickest patients in your study, because they're the ones who have the most opportunity to improve. And then, of course, exclude anybody who actually dies, because, that's bad. And so just exclude them from the study. Intention to treat, forget that, just exclude them. Number 5, there's a lot of different study designs available for health services research, but everyone, especially clinicians, know that the only ones that provide valid results are the randomized trials. And, as an epidemiologist, I've spent almost my whole career promoting the idea that we can actually get evidence from other sources. But in health services research, if you want to do it badly, only do randomized trials, okay? And only use data from those trials. And I guarantee you'll end up doing health services research badly if you do that. Number 4, Of course, when you're doing economic assessments, use any money measures you have and use them interchangeably. And in fact, if you can't figure out what to do, just convert everything into bitcoins. Okay, now I will tell you, if I had actually converted everything to bitcoins in 2015 when I made this list, I'd be retired right now because I would have made so much money that, but anyway. Again, there's no need for cost to charge ratios, adjustment for inflation, other manipulation. Again, if you want to do it badly. Number 3, if you do feel like adjusting, just use the medical care consumer price index to adjust your costs. Because after all, that's really what drives everybody's costs, right? The core inflation rate, it's not important. Use the healthcare inflation rate instead. Number 3, again, no need for theory or conceptual frameworks. Training is also optional. Anybody can do health services research and doesn't need any specialized training. Again, that'll end up not too good either. So we already established that, just have people who say they're health services researchers, but in an earlier item here, but making sure that it's bad would be to have people who say they're health services researchers who don't have any training. Okay, and then finally, the best way to do this work badly is to be completely unaware that there's any type of bias in your data. And if you do think there's bias, don't talk about it as bias, just say, oh, that's a causal effect. And you'll end up again doing health services research badly. Okay, now if that list is interesting to you, look me up at the University of South Florida. Just put my name into Google and University of South Florida and you'll find my page. I have about 40 top 10 lists there. I have actually made a number of additional ones that I haven't posted yet, but I make them frequently mostly for illustrative purposes, but usually to inject humor, but also making some points. Okay, so we're going to talk about spatial data. So it's an obvious thing. Firstly, I think that all health data are spatial. All social data are spatial, but they're not going to be spatial unless they actually have some kind of spatial referent built into the data set, right? Now, we have a lot of these. A geocode might be the nation or the state or the county or the zip code or the census tract, or it might be latitude and longitude coordinates. But ideally, you want to have the ability to reference a particular record to spatial location at some level or not. And the ideal would be to have latitude and longitude coordinates. Of course, the ideal would be to have daily activity monitors so you could actually track where people are spending all their time and so on. But I think that's probably a little bit invasive for most of us. Bad enough that they can tell where we're sending our Twitters from, Okay, so again, I could spend the whole lecture talking about geocoding. And if you want to have me come back, I'd be happy to do that, but I'm not going to do that. We're going to presume that we have geocoding that is the basis for working with our health data. And I do point out geocoding is a form of record linkage. It requires careful scrutiny, validation, and evaluation of results and so on. You can incorporate bias into your study. I will tell you, if you geocode the birth certificates for a state, there will be a certain percentage of them that are not geocodable. And if you tabulate your risk factors by what's geocoded and what's not, you're going to find that a significant excess of those that are not geocodable are actually the ones you really want to study because they have the worst outcomes. And so if you exclude them from your study, you're not getting a good population perspective. Also, the information in the records isn't always accurate. So this is a map that shows with the red pound signs the geocoded addresses of births that were reported to be in Denver, Colorado. See if this works here. Okay, so this is Denver that's kind of in the, I guess it's kind of a gray color. But you can see all these ones here that are actually living in another municipality, but the address that they gave said they live in Denver. So again, just because you have more than one spatial referent doesn't mean that they're all interchangeable and accurate. You have to be careful about how you use those records. And so in birth defects, which is a field I work in a lot, people use registry data to look at the prevalence of selected birth defects. We typically can't do small area analysis for this because we're dealing with the outcomes that are relatively rare. When you have an outcome where you have 2 or 3 per 10,000 births, census tracts are not a really sensible unit of analysis. But we frequently do analyses, and I'll show you some examples where people have taken multiple years of data and used techniques that borrow strength, doing smoothing, isopleth maps, probability maps, and so on. And a lot of times people do identify potential clusters when they do these analyses, and I'll talk about some of the methods that we have for that in a few minutes. But StatScan is one of the most popular in public health. Also, the Luke Anselin's measure of the local indicator of spatial association is another commonly used tool as well. So I wanted to make a point, though, about small areas. So I'm going to show you 3 maps for the city of Des Moines, Iowa. These are maps that were created by Dr. Jerry Rushton, who's now retired, but was at the University of Iowa and was one of the major proponents of working with spatial data to look at health issues. So the first map shows by zip code the infant mortality rate for Des Moines. And what you can see is the range is from less than 5 to 15 to 20 per 1,000. And you can see a couple of areas that are highlighted that have those higher rates. The second map shows the exact same data, but now we're looking at census tracts rather than zip codes. So one of the things you notice, first of all, there's a lot more census tracts than there are zip codes. Now look what's happened. The range now goes from 0 to 6 at the lowest up to 30 to 36, which is almost twice as high as what we had previously. When we take it down to census block groups, which are typically units of 4 to 6 city blocks, maybe 8, now there's even more units, and the range now goes up to 60 to 72. It basically doubled across the range. Okay, so the scale that you do your analysis at can make a big difference. And I can tell you that depending on which scale you use, you may actually identify different areas that show as having clusters. So you have to be careful. So again, just to make this point a little bit more concretely, let's say that we have 3 different areas. They all have the same low birth weight rate, 7%. Okay, one has 100 births, and there's 7 cases. One has 1,000 births, and there's 70 cases. And one has 10,000 births, and there's 700 cases. So if you do a statistical analysis where you use the low birth weight rate as a variable, all these areas are going to have the same value of 7 or 0.07. Okay, so they have the same mean, but what's the standard deviation? How certain are we of the utility of that estimate? Well, again, when you're using the binomial, you can calculate the standard deviation using a simple formula. I used an Excel version to calculate that, but that's the basic formula. And when you calculate the 95% confidence interval for each of those 3 estimates, the first one being the one that only had 100 births, you actually have a range from 3 to 13%. For the second one, it's 5.5 to 8.7%. For the third, it's 6.5 to 7.5%. So you can see that the larger the number of observations you have, the more precise your estimates are. Problem is, if you don't use a methodology such as Poisson regression, you're throwing away valuable information about your small areas. And most people, before they hear a talk like this, do regression analyses where they just use the point estimate in their analysis, and it's likely you're going to make some incorrect inferences if you do that. Okay, so just to hammer this point home a little bit more, I think it was 2 years ago I did a webinar with Mike Kramer from Emory University, and he put together some slides that I liked so much he said I could use them. And so again, looking at birth weight, This is a map of the very low birth weight rate for white women across the United States, and you can see it doesn't range too widely. The lowest category is about 0.8 to 1.1%, up to the highest category is 1.37 to 1.47%. It's no accident that southern states are more popular. Can't even tell for sure where Delaware is. It's kind of in there someplace or other. But when you look at the county, same data, but looked at for counties, it, again, in the same way that we saw for infant mortality, the lowest quintile still only goes up about 1.07%, but the highest quintile actually has an upper limit of 23%. That's probably a county where there were very few births and somebody had triplets or something, who knows, but those kind of things happen in the data. Well, looking at these data, there's over 3,000 counties. You guys don't contribute too much to the national conversation about counties with only 3, but there's over 3,000 counties. Well, it turns out that 273 counties in this particular data set had a very low birth weight prevalence, births less than 1,500 grams of 0, none at all. But then there's 25 that had, over 4%, okay? And in terms of the number of cases, 6 of those counties actually had more than 100 very low birth weight births. And so you have these extreme values that you're working with in the data. And then you have a great deal of uncertainty, and you can calculate the relative standard error, which is the standard error divided by the estimate. And turns out, statisticians will say, be careful if you have an RSE greater than 30%. More than half of the counties in the country have an RSE of more than 30%, okay? So then you have to say, well, what do you do about this? Well, there's a number of strategies that we have, but it basically, starting with what we have the numerator, we have the denominator, we don't want to throw that information away. We also know what the pattern is in adjacent states, or adjacent areas, whether it's county or census tract. And so one of the things we can do is inform our estimate by borrowing information either about the overall distribution or about the areas that are adjacent, and incorporate that into your estimates. And again, you can also allow the true outliers to be different, but don't allow sparse data to influence those outliers too much. So we have several different approaches. We can do aspatial multi-level regression. I'm kind of on a vendetta against aspatial regression because you have statistical information. If you're analyzing all the counties in the United States, if somebody asked me, well, Russ, can you get me the geographic centroids of all the counties in the United States? I could find that for you on the internet in less than 5 minutes. And pull it down as an Excel file that you could then incorporate into your analysis. It's there, easily available, not an excuse that you can't find the information so that you could make a spatially informed analysis. And the same thing is true in terms of finding, centroids for census tracts or census block groups. That information is readily available, and it's not an excuse that you can't find it. Now, might be an excuse that you don't want to do it, but I don't like that as a valid excuse. But the other, also aspatial and spatial empirical Bayes estimates are other methods that we have available as well. So this map shows the distribution of very low birth weight by county, and it's got a box plot that gives you an idea of where all the counties lie. And you can see that the vast majority of counties are relatively close to the mean, which is somewhere around 1.5% or thereabouts. But then you have all of these, this thing doesn't like to say, you have all these outliers and the tails of the distribution. They're the ones that are showing up in the orange and red across the country. This shows what happens when you do an aspatial multi-level model. So we had 30% with relative standard error greater than 30% for half the counties. When you do the aspatial model, it's only 26 counties, which is only about 1% of all the counties in the country. And you can see what's also happened to the point estimates after we do this smoothing. It helps quite a lot. When we do empirical Bayes, we get a slightly different map. It also has narrowed things a great deal, and now we have still about the same number, about 1%. And when we use spatial empirical Bayes, which borrows information, you can see if you look at the pattern, this is a much more diffuse pattern, whereas here things are clustered together more. This gives you, an estimate where it's really pulling the information from multiple counties together, and in the process of smoothing, it evens out the patterns that you see in individual counties. And again, it's random stair. The error is about 2% of the in the country are still falling into that. Okay, we have other methods that we can use for small area estimation as well, including fully Bayesian disease mapping. I highly recommend that you learn how to use R if you want to get into that. And there's a great textbook that Andrew Lawson has called Bayesian Disease Mapping that is a great tutorial on how to do that kind of work. We can also do kernel density smoothing, we can do kriging, we can do head banging, and there's a lot of different methods for that. So there's a lot of things you can do. The reason I'm bringing this up is that if you're really interested in doing this kind of small area type analysis, you need to incorporate these approaches into your modeling strategy. But I strongly recommend doing it in a way where you can do, hierarchical or multi-level Bayesian modeling where you bring in information from your different levels, but it needs to be spatially enabled. And ideally, it doesn't have to be done in a Bayesian framework, but computationally that tends to be an easier way to get the job done. So this is a map, another thing from Jerry Rushton's project. I showed you previously the rates. And here what he's done is he's actually created a probability map to identify the areas that have an infant mortality rate that's greater than their surrounding area. And interestingly, it shows, a peak. There's some place in this area that is coming up with an infant mortality rate of over 150 per thousand. This particular one here is not quite as high, but also a major peak that is showing up. And the reason for pointing this out is that Rushton created a spatial filter method, and the competing method is Kuldorf's SAT scan, time-space scan statistic. There's a lot of people that use both of these. This paper I'm just going to briefly mention is one of the few I've seen where they actually did a heads-up comparison of the two methods using the same data set. Now you might be wondering, why did they do that? Well, it turns out that Dr. Kirby was the reviewer of the paper, and I told them to do it. And so, but it's nice that they did, and we have it in the literature. So what this is showing is, they're looking at Shelby County, Tennessee, where Memphis is located, and you can see here the SAT scan has identified a cluster in this area here. The spatial filter is identifying several clusters, but this is using a window of 0.4 of a mile, which is about 2,000 feet. When they change the filter to a half a mile, or about 2,500 feet, a couple of other places show up in the SAT scan, and more areas are being highlighted with the spatial filter. And when they incorporate more to 0.6. So the bigger the filter, the more likelihood is that you're going to find other areas. But the interesting thing about it is that all of the places identified by the SAT scan clusters are also falling inside, the areas identified by the spatial filter. So the spatial filter is telling a little more complex story, but it's basically the same story that you're getting from each of these methods. This is a methodology that you could easily use. I'm not sure how well it works. So one of the problems you have when you work with these kinds of methods is that they're heavily dependent on the spatial density of the outcome that you're studying. And so what people have done, for example, with SAT scan, is they've created a way to have an adaptive window based on density so that you can adjust it within the analysis. But you definitely have to think about that if you wanted to study across the whole state of Delaware, where you have basically a metropolitan population in the north, and then a lot more chickens than people in the south. You have to have a way that you can accommodate the density differently. I've got a few other maps. This is a map showing the spatial distribution of gastroschisis, an abdominal wall defect in Canada, and illustrates some interesting patterns. They're finding in the lowest level category less than 2 cases per 10,000, and the highest 5.7 per 1,000, which is a pretty big difference that you can see. And you can see there are a few areas. These are fairly large geographic areas. You want to remember with Canada that something like 70% of the population lives within 100 miles of the U.S. border. So, this area that has a high rate probably didn't have a whole lot of cases because there's not that many babies being born there. But again, being able to visualize, just making a map like this allows you to identify some potential questions that might be interesting to analyze. When they looked at clusters using SAT-SCAN, actually this was using the Marrell statistic, the local indicator, a lot of the noise from the previous pattern goes away, and these areas that are red are areas that have high prevalence, that are adjacent areas that also have high prevalence, and the areas that are blue are the areas that are low, adjacent areas that are low. So if you wanted to get a better understanding of this disease, I would focus on areas that are in the high or the low, because those are the ones that are going to give you the best clues as to what might be going on. This is another project looking at gastroschisis. This is from Masa Yazdi's dissertation, and she's looking at the state of Massachusetts. And here we have the smooth crude odds ratio for actually I think this is for non-Hispanic women age 25 and older. This is for non-Hispanic women who are no, the first one is the whole state, and then it's broken out. This is women 25 and older. This is women less than 25. Doesn't actually show dramatic differences, but there's some interesting patterns that you get from this. One of the problems with doing these analyses is you have to be worried about boundary effects, and the fact is that they don't have any data for New Hampshire and Vermont and Rhode Island and so on, so you don't really know for sure what the meaning is of these patterns where you have an elevated rate or a low rate that's right on the border of your study area. So you have to be a little careful interpreting. Here's another, also for gastroschisis. Gastroschisis is one of the birth defects that people have done the most with in terms of applying spatial approaches, which is why I'm showing it. But this is, again, a study looking at clusters and identifies primary and secondary clusters. They're the ones that are kind of in this hatched and shaded area, and they look at it a little bit more closely here. And you can get and they analyze the data both adjusted for maternal age, also looking at race, also looking at parity and other factors that have been implicated. And they're telling mostly the same story. This is an area where you have the highest level of aggregation. So from a public health prevention point of view, that would be an area that one might want to target. I'm not sure exactly what the intervention is going to be for gastroschisis, because we still have a mystery as to exactly what the etiology is. But still most people do think it has an environmental or a gene environment basis to it. And so potentially looking for environmental factors that might explain these patterns. Now, we can also use these spatial approaches to improve surveillance. And this is an example from a paper published in Health and Place a number of years ago from New York State. And in this particular area, they identified across the state areas that had higher than expected prevalence of birth defects and lower than expected prevalence of birth defects. and there wasn't a lot of rhyme or reason to what those were. And so they went to a deeper level, and they actually mapped out using the location of the hospitals where the births are occurring. And what they found, actually the interesting thing is, the circles are different sizes in relation to how many case reports had been made from each of the hospitals. And then the colors within the circles have the percent of cases that they were able to identify from an independent source that had actually been reported. So it turns out this area, this is Manhattan and the Bronx, that had a deficit. Turns out it really was. They've got a hospital here, a pretty good sized hospital, that reported less than half of the cases. How do they know that? Because they have an independent data source from their statewide hospital discharge records that indicated birth defects, and the hospital wasn't actually reporting them to the registry. And so they were able to hone in on that and work out ways to improve it. And when they were all done with that, they still had another area that showed up as a deficit when they went back. And look, it's a never-ending process. You know, you have to build these quality measures into your program and keep working at them. Okay, I'm not going to go through this flow chart here in detail, but this was a project we did in Florida where we had a colleague who was a medical geographer who took the statewide data and did his own geocoding and compared the results with, basically using two different methodologies and so on, and that's what the flow chart is. But then what we did with it, because we have our data longitudinally linked, so each child with a birth defect, we had the hospital utilization through the Florida, it's called the Agency for Healthcare Administration. We were able to look at where they were going for care, and we're able to identify quite a few people who were going some really long distances to get follow-up care for their child. And you can use this kind of information to make recommendations about where higher level clinical services ought to be located to be most efficient for the population. Now, we're not in a position of power where we can convince HCA or other healthcare organizations to actually do this, but at least we can point out where there are inefficiencies that might make sense to be addressed. Likewise, with the Texas Birth Defects Registry, they mapped out the distance of birth defect cases to the nearest genetics clinic. And you can see there's some areas around here in West Texas and along the border where there's a lot of cases that have very limited access to clinical genetic services for follow-up. And again, GIS can help us from a health services point of view, to identify these kinds of inefficiencies. Again, whether they have the clout to make things change, I don't know. So I've got one additional example I wanted to share with you. This is an unpublished project. If anybody's really entranced by it and wants to talk with me about replicating it with more current data and possibly doing a paper, I'd be happy to talk with you. But I was interested in better understanding the factors associated with certified nurse midwife delivery in the United States. And in 2000, according to birth certificates, which most people think under-identify CNM assisted deliveries, there were 7.3% were delivered by nurse midwives. It varied from 1.6% across the state of Missouri all the way to more than a quarter of births in the state of New Mexico. And when you looked at counties, a quarter of all the counties had no CNM assisted deliveries, whereas there was a county in New Mexico where 75% of the births were assisted by midwives. And so I started out, I made a map. This shows the distribution, and you can see, the areas that are in red are the areas that have the highest rates. Not coincidentally, they tend to map up pretty well in terms of where there are Indian reservations in the West, and a lot of the women, getting their care through the Indian Health Service use nurse midwives. South Dakota shows up there as well. Some pockets in the Florida Panhandle and so on, places in the deep south where it's very hard for CNMs to practice. And when we smoothed the map, you can see this is using one of the Bayesian smoothing approaches. You can see that it highlights these areas even more clearly when they are smooth. And so we built a Poisson regression model where we had county level information. It was not a multi-level model that we fit, but there were over 3,000 county equivalents. And we put a number of variables that we obtained both from the National Vital Statistics, along with some data we obtained from the Area Health Resource File at the county level, and looked at variables, and our key variables were all significant. Not having an obstetrician definitely increased the likelihood of having a CNM-assisted delivery. And anyway, we saw some patterns that were statistically significant. And then what I did, which it may be a little bit unusual in doing this, but I thought, why don't we map the residuals from the model? And so if you think about residuals, from a regression analysis, the whole idea is the residuals capture the unexplained variation in the model. Well, there's a lot of unexplained variation. We had a pseudo R-square of 12%, meaning 7/8 of the variation is still unexplained, right? And so looking at the residuals, what you're really interested in are the residuals that are greater than 1.96 in absolute value, which corresponds to p of 0.05. And so this is what that map looked like using the raw standardized residual data. And here, the ones that are red are the places that are below what is expected, and the ones that are green have rates that are above what is expected. Okay, and you can notice there's some clustering in upstate New York and New England, some places in Florida, New Mexico and Arizona. Again, the reservations are still being highlighted. But when we took those data and we ran it through the local indicator of spatial association, which I talked about a few minutes ago, unfortunately the colors are the opposite here. But what's interesting is there's something going on over and above all the variables I have in my model in certain areas of the country. And I happened to be a professor at UAB at the time. UAB is right in the middle of this cluster that's blue. All of these counties here have significantly less likelihood of CNM-assisted delivery than the model expects. I go over to North Georgia or the Panhandle of Florida, and all of those counties that are red have significantly greater likelihood of CNM-assisted delivery. So we start thinking about that, and it makes one think about health system issues and practice environment and so on. I can tell you that if you're a CNM and you want to actually deliver babies in a hospital in Alabama, good luck. The medical establishment has so much control over what happens that you will have a great deal of difficulty finding a hospital where you're allowed to practice and having an obstetrician who's willing to supervise you so that you can actually have practice privileges. Well, in North Georgia, they have a different idea about that, and they make it much easier. And so there, you have a higher proportion than would be expected. Out here, again, the areas where there's reservations are being highlighted, I think, because of the policies and practices in the Indian Health Service and also cultural practices as well. There's an area out here on the West Coast, highlighted in Oregon, also in Northern California, where you also have higher than expected. But the whole point of this is you do this analysis, and it enables you to see other factors that might also be part of the story. And then if you can find a way to measure those factors, you can build them into your model and have a more predictive model. Okay. Now, we won't argue the merits of whether we need to have more CNM-assisted deliveries. That's, an interesting conversation as well. But this gives you a notion of what you can do with the data and how you can potentially interpret the results. So there's a lot of things that could be improved with my study. I would definitely make it a multi-level modeling approach. I would probably do it using spatial Bayesian model fitting strategies nowadays. I'd probably build in more data, possibly look at trend over time, build in more individual level covariates that might help to explain the patterns more as well. But it gives you an idea of some things. So I'm near the end of what I'm going to present. I love this cartoon from the New Yorker where they're at a party and someone's saying to the hostess how it was typically brilliant to have invited an epidemiologist. So that's good. But I want to point out that anybody can make a map and anybody can run a statistical analysis. You can map any data set in many, many different ways, all of which are potentially valid. But what your goal is to identify what are the relevant patterns so that a person reading the map can focus on what they mean. Likewise, GIS isn't the solution, it's a tool. And we have a lot of other tools that we have available as well. And of course, in the hands of some, tools are weapons, and for others, they enable us to do better work. People always ask me, what kind of software should I use? And my answer to that is, it really depends on who you are and what you want to do. There's all kinds of freeware and shareware available. I actually don't have QGIS on this slide. I should add it. But a lot of people do all their work in R. It does require learning how to use R, but there's hundreds of spatial packages that have been built for R. But if you can talk Christiana Kerr into getting a site-wide license for ArcGIS, that would be great. So I wanted to conclude by sharing with you the 10 commandments of public health GIS. And some of these are, see, if I were Moses, I wouldn't have stopped at 10 commandments. There are a couple of things they really missed out in the 10 commandments that are actually practical. Like, I think one of the 10 commandments should be know thy purpose. We're all here for a reason, and we should know what it is we're here for and how to accomplish that. But it's not in there. So anyway, we have the 10 commandments of public health GIS. Okay, so firstly, you shouldn't expect health outcomes or disease states to respect any of the boundaries in your data. They don't. But if you don't collect geography within your data, you don't have anything you can map. So you have to recognize that your boundaries are imperfect, but you have to work with that. Okay, thou shalt not unknowingly commit spatial errors. Pretty hard to live up to that one, but we all do it. In fact, if you want to commit spatial errors, just use Google Maps as a device for getting places. Okay, but here we have know thy purpose. This is related specifically to public health GIS, and you should always be cognizant that the scientific method is not a built-in feature of any software that we might be using. You have to bring that in yourself and make sure you do things that make sense. Number 7, you should know and understand your data before you start working with it within the GIS. And then once you have it in the GIS, you still have to explore it to find out what's going on. Okay, so you also want to remember that your map is an abstraction, but it also reflects the environment and data representing actual events that happen to individual people. And you want to respect that as you're working with and interpreting the data. Privacy, hugely important. You have individual records that have specific locational identifiers. In terms of PHI fields, you're right in the mix of all that. And the more information you have about those individuals, the more important it is that you protect that information as closely as you can, not just in terms of who you let sit down at your computer and work with your database, probably don't want to do that unless they have IRB approval on your protocol and so on. But when you're presenting results from the data as well, you want to be thinking about how to make sure that you don't inadvertently produce something that could identify an individual. And then this is the Edward Tufte item here. For any of you who are familiar with Edward Tufte's books on data visualization and so on, but you should not clutter your map with unnecessary elements, layers, map elements with what he calls chart junk. But you want to make sure you include necessary information for people to interpret the patterns on your map. So you kind of have to be walking between those two different extremes. Number 4, again, this is from a famous cartographer from the 20th century who said, the real art of cartography is knowing more what to leave out, more than what to put in. So think about that. Know thine metadata. Store thine metadata. Make sure that if somebody comes along and wants to use your GIS 2 years after you leave, they can figure out what you did and how it got there and how it can be used. Number 2, this should actually be a higher level commandment than this, but never assume that the default settings of any software are going to generate something useful. And I can tell you it doesn't matter what it is. PowerPoint's a great example of an application where you're not going to get a good result if you use the default applications. You always have to put in settings that make sense. And then finally, you should show humility to others and be gracious even to those who thought it would take weeks for you to do what you did this morning. Okay. So I'm going to leave my email address and phone number up. If anything I've said, strikes a chord and you want to follow up, I really do enjoy collaborating with people, and I do a lot of that both nationally and internationally, and would be happy to talk with you about projects you might be doing. Pretty much everything I've shown here can also be done just using data within the healthcare system. But obviously, I'm also a population health advocate and would think about reaching out and capturing the whole population. So I'm going to stop there and see if anybody has any questions. Okay.
So when creating maps, sometimes you're in discussions with people who see the map as the end versus the map as
the map is really earlier in the process. Yeah.
Discuss.
Yeah, that's a constant issue, and it gets into the whole question of pattern versus process, and there actually are lots of geographers whose goal is to make maps. And I've always seen, the map is a reflection of one way to look at the data at this particular point in time. But what we're really interested in, what led that map to look like it is? What are the underlying factors that are involved? And in public health, there are so many different directions you can look at to better understand that the map is only the beginning. Yeah. Other questions, comments, thoughts? Emotional disturbances? Yeah.
Appreciate the point about level address data and how we split it. And we use a lot of data mapping. So
yeah, well, I can tell you a story about that. When I worked in Little Rock, I was the maternal and child health analyst. I had a job similar to what Khalil does in Delaware, except that I was the only one doing that kind of work. And one year, there was a concern that infant mortality had really spiked in Pulaski County, which is the county Little Rock is located in. And I thought that was interesting. So back in those days, you could go down in the basement. Well, not anybody, but somebody who worked in the health department could go down in the basement and actually look at the original birth and death certificates, which in those days were hand-typed, individual records. So I went down and I started pulling death certificates that had Pulaski County as place of residence. And I noticed a pattern that there were a whole bunch of babies who died whose address was 800 Marshall Street, which was the mailing address of Arkansas Children's Hospital. And what was really going on, Arkansas Children's Hospital did not have a labor and delivery unit. Every baby who went into that hospital was transported from somewhere else, usually not in Pulaski County. And they were all these babies were being counted as if they were residents of Pulaski County and died, you know. And looking at, it was necessary to go and look at the records in order to make that observation. I was then able to tell the people in Vital Statistics they needed to go over and have a chat with the people creating these death certificates, and that really what we're looking for is with a baby, we want the mother's address at the time of birth to be the address that's reported on that infant death certificate. And they were able to fix that, and you know, it's hard to clean up the data once they've been filed and processed, but at least we were able to fix it moving into the future. But yeah, you can't accept. Another example I'll give you from Wisconsin. They made a statewide map of breast cancer incidents, and Appleton, Wisconsin was highlighted as having areas that had way higher than the state average and much lower than the state average. I took one look at the map. I said, "You idiots, don't you know that Appleton was divided into 3 zip codes during the middle of your study period? And the reason that this one doesn't have very many cases is because nobody's using the new zip code yet." And I told them, "You've got to put those 3 back together into one unit to get reliable information." When they did that, it was almost exactly the state average. Yeah.
So you've worked a lot across different states and have collaborated. What advice would you give, or how easy has it been to share these kind of information from one place to another?
Yeah, that's a tricky thing. When the collaborations that I do usually don't involve me actually having the data. You know, it's more working with people in study designs and in looking at results, map and table and things like that, and giving input at that level. You have to be very careful. I mean, you're dealing with, you know, HIPAA protected information usually, and you want to keep the actual data, you know, close and abide by all the privacy and confidentiality considerations that you have. Now, if you wanted to get the national data that I was showing, like for the nurse midwife study, what you have to do is you have to fill out an application to NAPSIS, the National Association for Public Health Statistics and Information Systems, requesting the national vital statistics data with the geography fields populated. Anybody can go and download the whole national natality file. You could do it on that computer right there in about 5 minutes. But it's not going to have any information in the fields for state of residence and county of residence and county of occurrence, because you know the vital registrars are concerned about having that level of data, particularly since there's so many individual fields that it would be potentially possible for somebody to reverse engineer and actually, you know, identify individuals from the data. So they have this process where you can apply to get that information, but you know, there's all sorts of requirements that you have to agree to. But every project that I've wanted that for, I've been able to get the permission, you know, to get those data, but they don't release it to the public. On the other hand, they have CDC Wonder, which is going to give you county level information if you want it. Many, you know, the March of Dimes had an application called Perry Data, Perry Stats, I think theirs was called, that unfortunately it doesn't have current information right now, but that also allowed people to get you know, a look within state at data as well. But if you want Delaware data, just talk to him. You know, he'll tell you, Miss Khalil. he can tell you where to access that. Yeah.
Thank you very much.
Thanks.